today it will be like a mock exam. The difference will be you will be learning a lot in this scenario, because this is a place where I will interrupt and I will correct you as well. It is not just going to be a one-way lecture. Probably it will be an interactive session between me and Ved, and if anybody else is also willing to contribute. So this was all about your inspection, right? Anything else you mentioned in inspection?
I noticed a longitudinal scar of 1 centimeter inside, just above the cubital fossa in the anterometal aspect, sir, because of the biopsy done outside.
Okay, fine. So, and what are the negative histories that you have asked?
There is no any obvious axillary swelling seen on inspection.
Yeah, why that?
Because there are some histologies which are associated with lymph node metastasis.
Okay, so what you are asking, what you are trying to say is rule out lymph node metastasis. So, when you say this thing, that lymph node metastasis, so the next question that the examiner is going to ask you, which tumors metastasize to the lymph nodes?
Yes, sir. There are some histology like clear cell carcinoma, clear cell sarcoma, lymphosarcoma, epithelioid sarcoma, angiosarcoma, rhabdomyosarcoma, myxoid liposarcoma, and synovial sarcoma.
Okay, so the swelling is somewhere here, and see, there are two ways by which the swelling may dislodge and cause metastasis. One is the hematogenous spread via the bloodstream. The other is by the lymphatics. So it may be asked in different ways. So normally, what is the common mode of metastasis? How do sarcomas metastasize?
Sarcoma mainly metastasizes by hematogenous routes.
Yeah, so this is hematogenous. So what percentage? I know I'm asking too much, but what percentage goes hematogenous? What goes lymphatic?
80 to 90%, sir. Hematogenous lymphatics, less than 10 to 12.
Almost 85%, and this is almost 15%. So which ones goes lymphatic spread? You said one or two. So there is so you should remember at least 3 or 4 names. So this is rhabdomyosarcoma, alveolar sarcoma, clear cell sarcoma, epithelioid sarcoma, synovial sarcoma. So mostly these metastasize via the lymphatic spread. That's why we need to examine it very well. You don't know right now, you don't know the histology, you are just examining. So you have to complete your clinical history and examination in a way so that you arrive at the right diagnosis. Okay. So now we come to the palpatory part. So yes, go ahead.
So on palpation, I confirmed the inspectory findings. There is no local rise of temperature or no tenderness. 20 by 20, 22 by 15 centimeters swelling in the anteromedial aspect of left arm, globular in shape, extending superiorly from left anterior axillary fold to inferiorly up to cubital fossa. The circumference is 26 centimeter, 10 centimeter above the cubital fossa, while the opposite arm has the circumference of 15 centimeter at the same landmark. The surface of the swelling is lobulated. Consistency is variable, soft to firm. The margin is ill-defined and irregular. The mobility is restricted side to side, and the swelling is completely immobile along the axis of taut muscle.
Swelling is
restricted. There is restricted mobility side to side, and the swelling is completely immobile along the longitudinal axis.
okay.
However, the swelling is mobile over the underlying bones in both axes.
Okay, very good.
The upper half of the skin over the swelling is not pinchable, while the swelling in the lower half is pinchable. the
Okay.
skin of the swelling, sir.
Okay.
And a scar of 1 centimeter is placed longitudinally, which is healed by primary intention. There is no suture mark or drain site noted.
Okay.
Uh,
There is drain site is there.
no, sir. Only
So this
primary
is
healing.
so this is the scar which you are saying anterolateral.
Yes, sir. Yes, sir.
Fine.
No axillary lymphadenopathy and non-pitting edema of the left hand is seen.
Okay.
Then neurovascular, shall I proceed to neurovascular examination?
Yes. Now complete your examination. Then I'll take up the points one by one.
Yes, sir. Yes, sir. On neurovascular examination, low muscle wasting distal to swelling, range of motion of left arm is restricted above at shoulder joint in the form of painless terminal restriction while doing adduction and medial rotation, and below at the elbow joint in the form of painless terminal restriction while doing flexion and supination and pronation. The power is reduced in left arm 4/5, while the right upper limb has the power of 5/5. There is normal sensory examination in all the dermatomes, and the left axillary, brachial, radial, and ulnar artery pulse would be palpated, but the volume was less as compared to the right counterparts.
Which
Deep
one?
tendon,
No, where? Which was less?
brachial, radial, and ulnar.
Okay.
And deep tendon reflexes was preserved.
Okay.
And on auscultation, there was no arterial blue or venous hum heard over the mass.
Okay.
So this is
Right. So good. Now let us see the points.